Hello students. Hello students. Today's class is on healthcare associated infections or nosocomial infections. By the end of the class, the student should be able to list the types of healthcare associated infections, know the pathogens associated with nosocomial infections, recognize the common risk factors, and understand the preventive strategies of these healthcare associated infections or nosocomial infections. Now the abbreviation I've given for the healthcare associated infection is HAIs. Okay. Looking into the definition, infections acquired by a patient in a healthcare facility after 48 hours of admission and which was not present or incubating at the time of admission, and which also includes occupational infections among healthcare workers, are known as healthcare associated infections. So this infection, it occurs in a healthcare facility. Healthcare facility can be an hospital, nursing home, or any rehabilitation center. And it occurs after 48 hours of admission. And it also includes occupational infections among healthcare workers. Okay? What are the occupational infections among healthcare workers? They can be needle stick injuries. Looking into the predisposing factors, they are advanced age, more than 60 years, compromised immune status like cancer or immunosuppressive therapy, comorbidities like diabetes, asthma, etc., virulence of the agent, several diagnostic and therapeutic interventions like use of IV line, Foley catheter, endotracheal tube, which might be the source of infection. Breach in the standard precautions like inappropriate hand hygiene or not wearing the personal protective equipment. Next is inappropriate antibiotic use. What happens when you inappropriately use antibiotic? That is, you use the antibiotic where it's not needed, or you're using a wrong antibiotic. We know that there's a lot of flora in and on within the human body, most of which are sensitive to antibiotics. So all of them are killed and couple of resistant forms remain. They overgrow and they pass on the resistance to other bacteria too, which is very harmful. Next risk factor is the hospital environment. Inappropriate cleaning and disinfection of hospital environment as well as the instruments. And transfusions, blood transfusion of blood and various blood products are also the risk factors. Looking into the pathogens, most of the multi-drug resistant bacteria are the main culprits. One group is the escape pathogens. This escape mnemonic stands for Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter. These constitute the escape pathogens, which are multi-drug resistant forms, and other bacteria include Escherichia coli, Clostridium difficile, and other Clostridium species too, which exist in the hospital environment, also in the operation theaters. And then airborne infections like Mycobacteria and Legionella, fungi like Candida, Aspergillus, zygomycetes like Mucor rhizopus, and viruses like HIV, HBV, HCV, which are transmitted by needle stick injury or by transfusion, and viruses like measles and varicella zoster, that is chickenpox virus, which are transmitted by airborne route. And there are also other viruses like rotavirus in pediatric wards, etc. Looking into the source can be endogenous or exogenous. Endogenous source is the patient's own flora. This flora at one site in the human body, when it enters the other site, can act as a pathogen. Say you're introducing the Foley's catheter. The periurethral flora mainly is the Escherichia coli, which when introduced into the urinary bladder while introducing the Foley's catheter, acts as a pathogen in the bladder, causing urinary tract infection. Okay, so this is about the endogenous source. Next, about the exogenous source is external source, the environment of the hospital, the fomites, the instruments, the air, the water are the source of infection, and healthcare workers as such, when they are treating the patient, they might be colonized with the microbes from the patient, like methicillin resistant staph aureus might colonize their nostrils, and this can be transmitted to other patients. Okay, looking into the modes of transmission, they can be by contact, by inhalation, or by ingestion. Direct contact is the most common route. Direct contact with other patients or with healthcare workers. Indirect contact with the hospital environment, the fomites and the instruments. Inhalatory route. Okay, inhalation of microbes, either more than 5 microns, it's known as droplet infection, or those who less than 5 microns is known as airborne infections. So the droplet nuclei, which are more than 5 microns, once they are coughed out from the patient, they can travel up to the distance of 1 meter, that is 3 feet. Whereas airborne droplets, which are less than 5 microns, remain suspended in the air, and they are the source of airborne infections like Mycobacterium, measles, and varicella zoster viruses. If you look into this picture here, this first picture is the skin scales which are harboring staphylococci, and a normal individual, in a normal individual, about 1 million scales are shed in a day. So the contact with these skin scales might be a source for staphylococcus infection. Looking into types of healthcare associated infections, they are urinary tract infection, pneumonia, bloodstream infection, surgical site infections, gastrointestinal tract infections, skin and soft tissue infections, central nervous system infections. Say you have placed some shunt or done some operation on the brain. Eye and ENT infections. Let us look into the major types of hospital acquired infections. They are device associated infections and surgical site infections. Looking into device associated infections, which are acquired by use of devices, like indwelling urinary catheter causes catheter associated urinary tract infections. Use of mechanical ventilator and endotracheal tube results in ventilator associated pneumonia. Use of central lines can cause central line associated bloodstream infections. What are the strategies to prevent these healthcare associated infections? There are standard precautions like hand hygiene, use of personal protective equipment, environmental cleaning, disinfection of the instruments, safe handling of sharps, biomedical waste handling, isolation precautions, etc. Next is screening and cohorting of patients. What does the screening and cohorting of patients mean? Say you're suspecting the patient to have been colonized with or infected by a multi-drug resistant bacteria. You have to screen for, do the culture and screen for, and if he's suffering with this multi-drug resistant form of bacteria, you have to isolate the patient. So you can cohort the patients, that is, you can bring in the patients who are colonized or infected with the same multi-drug resistant pathogen and place them in a same room. This is known as cohorting of patients. Next is surveillance of healthcare associated infections is very important component. What you do here is, the surveillance is a systematic ongoing process of collection, analysis and interpretation of healthcare infection data, so that you can detect, you can identify the risk factors, you can identify the outbreaks, and you can implement or improvise the infection prevention and control measures. Next is antibiotic stewardship. It's a coordinated program which promotes the use of appropriate antibiotics. That is, it prevents the use of inappropriate antibiotics. By doing this, we can improve the patient outcome, we can decrease the resistant bacteria, and also prevent the spread of these bacteria. Next is screening and vaccination of healthcare workers. It's very important to screen healthcare workers for MRSA, for ESBLs whenever you suspect, and also vaccination of healthcare workers. It is mandatory for the healthcare workers to take vaccines like hepatitis B virus vaccine, measles, varicella zoster, etc. Then other strategies include needle stick injury management, patient safety improvement at every level, be it OT, operation theatre, during any interventions, and education and training of the entire staff. We've already learnt about the standard precautions. Let us move on. Let us look into first healthcare associated infection, that is urinary tract infection, which is the most common nosocomial infection, which accounts for 30 to 40% of all these infections. And the risk factors we've already studied. We'll only concentrate on those which are we have not studied at that place. Like the female sex is a risk factor. Female preponderance is because of the short urethra and close proximity to the vagina and anus. And Foley's catheter, which is an indwelling urinary catheter, is a very important risk factor causing UTIs. It contributes to 70 to 80% of UTIs, and it's known as catheter. The UTI which is caused by use of Foley's catheter is known as catheter associated urinary tract infection, which is also known as COTI. So let us learn a little about the Foley's catheter. So this dark yellow portion is the catheter. You can see that at one end there are certain openings to collect the urine, and at the other end there's a bifurcation having two ports. One is a bigger port which is a connection to the bigger lumen in the catheter, and other is a lumen which is smaller, which is a balloon port which connects to the small lumen in the catheter, which is used to inflate the balloon which is kept at the proximal end or the part of the catheter which enters the urinary bladder. So the balloon is inflated with the help of sterile saline so that the catheter stays in place. This catheter is inserted via the meatus into the urinary bladder, and the balloon is inflated via the balloon port. And you can see that the catheter is connected to the drainage tube which enters the collection bag. Okay, it's preferred to use a closed drainage bag. Initially they used to use the open drainage bag, which was important source of infection, and once this collection bag is 2/3 filled, or every 8th hour you have to empty it with the help of from the emptying spout into a jar. Okay. So this is how the catheter is placed via the meatus. You can see in the picture here, into the urinary bladder. And the picture F is the collection bag. It's a closed drainage system. And picture B is the double lumen of the catheter. The bigger lumen which is draining the urine, and the smaller lumen is the balloon port which is used to inflate and deflate. You inflate the balloon once the catheter is introduced into the urinary bladder. Okay. So looking into the definition of COTI, a urinary tract infection where an indwelling urinary catheter was in place for more than 2 consecutive days in an inpatient location on the date of event, with the day of device placement being day 1, and indwelling urinary catheter was in place on the date of event or the day before. So to understand this, let us look into this table. Say, look into the first row. Say that day 1, the Foley's catheter was introduced. It was in place on day 2. On day 3, it was removed. And on day 4 is the date of event. That is day 4, you have detected that there is CAUTI or catheter associated urinary tract infection. If you look into, was the catheter present for 2 consecutive days? Yes, first day and second day. And when was it removed? It was removed just a day before you detected the CAUTI. So this criteria is fulfilled. But if you look into the second row, the date of event was day 4 and the Foley was in place only for 1.5 day, day 1 and part of the day for day 2. So this doesn't meet the criteria of CAUTI. Okay. So what are the pathogens which are associated with CAUTI? Mainly they're drug-resistant, multi-drug resistant bacteria. In short-term catheterized patient, the pathogens are Escherichia coli, Klebsiella, Enterococcus, coagulase negative Staphylococcus and Pseudomonas mainly. And in long-term catheterized, more than 30 days, the pathogens are Proteus, Providentia and Morganella. Looking into the pathogenesis, the most common route is the extraluminal spread. So when you're trying to introduce the catheter, along with the catheter, you're also introducing the endogenous flora of the patient, which is lying in the periurethral area. This happens when the aseptic technique is not followed and this periurethral flora is introduced into the bladder, causing infection. Or the flora on the hands of healthcare workers, or by performing inappropriate technique, the pathogens or the bacteria through the hands of healthcare workers might sit on the catheter and may be introduced into the bladder. Next is the intraluminal spread, which happens when the drainage bag is not emptied properly, okay, or there is some break in the closed drainage system which causes reflux of contaminated urine into bladder. Other causes are biofilm formation by Staphylococcus, by Pseudomonas. They stick onto the catheter surface. They excrete an exopolysaccharide. They start multiplying within this, and they are resistant to to the antibiotics and to the uh, host immune cells because of the presence of this exopolysaccharide matrix around them. They will be embolized, detached, and they reach the bladder to cause infection. Next, the rare causes like struvite stone formation happens when there's protease infection. What protease does is it converts the urea in the urine into ammonia, increasing the pH, causing struvite stones or hydroxyapatite stones, which cause urinary obstruction. Okay, so you can look in this picture. The extraluminal spread, which is more common, and intraluminal spread, and the biofilm formation of Staphylococcus. Looking into diagnosis, you can diagnose by clinical criteria, that is signs and symptoms like fever, rigors, flank pain, pelvic pain, and incontinence. Okay, or microbiological criteria, that by urine culture, which is quantitative culture, and upon culture you should isolate the bacteria whose colony count is more than 10 to the power of 5 per ml of urine. Then only it is considered significant and it's known as significant bacteriuria. What if you isolate 2 organisms? At least one organism should have the count of more than 10 to the or equal to 10 to the power of 5 colony forming units per ml of urine. If more than 2 are isolated, it's not considered. Okay, so you're doing a quantitative culture, that's why you're giving even the count of the bacteria and hence it's known as this count of more than 10 to the power of 5 colony forming units per ml of urine is known as significant bacteriuria. And one important thing here is sample collection in catheterized patient. Where do you collect? So let us look into this picture. You can see at the junction between the catheter and the drainage or collection tube, you collect the urine with the help of a syringe from the port which is the catheter port which is connected to the drainage tube by following aseptic measures. This is very important. Looking into COTY prevention, how do you prevent? What are the preventive measures taken? Standard precautions like hand hygiene, wearing a glove, following an aseptic technique, and even before introducing the catheter, you have to do periurethral cleaning and maintaining the closed drainage system appropriately. That is, it should be below the level of the bladder and it should not be lying on the floor. You have to secure the catheter which is lying outside the body with the help of a tape onto the thigh, so that it does not kink the catheter. Then regular emptying of this closed drainage bag. I already told you that every 8th hourly or once it's 2/3 full, it has to be emptied. And daily assessment for the need of catheter. Is the catheter needed or not should be assessed daily. Say you have introduced the catheter and the patient has UTI, or he has incontinence, or he has urinary obstruction. That's the time when you have to remove the catheter. Okay. When do we use Foley's catheter? What are the indications for use of Foley's catheter? When the patient is unable to pass the urine post-surgery, and then when there is urinary obstruction, you use the Foley's catheter. Long-term immobilized patients, you use Foley's catheter. Next, let us move on to pneumonia. It accounts for about 15 to 20% of healthcare associated infections. Looking to the types, it can be healthcare associated pneumonia where the pneumonia occurs 48 hours after admission. Next type is ventilator associated pneumonia, wherein the pneumonia develops in a patient who's on mechanical ventilation for more than 48 hours. So looking into appropriate definition, ventilator associated pneumonia is a pneumonia where patient is on mechanical ventilation for 48 hours on the date of event, with the day of ventilator placement being day 1 and ventilator was in place on the date of event or the day before. So it's almost these criteria similar to that of UTI. Okay. Let us move on to ventilator associated pneumonia risk factors. The risk factors are like advanced age, asthma, ET intubation. What happens when you put a ET tube for mechanically ventilating a patient? You have to put first you have to either do tracheostomy or put an endotracheal tube. So when you introduce an endotracheal tube, this tube itself is a source of infection. Humidifier which is present in the mechanical ventilator or the ventilatory circuits are the source of infection. The nasogastric tube which is inserted to feed the patient is a source of infection, and certain prophylactic measures like H2 antagonists given to cure the stress ulcers which develop will raise the pH, gastric pH, and will allow the bacteria or the pathogens to grow, which can be the source of infection. And sedation medications will inhibit all the reflexes and can be the risk factor for infection. Looking to pathogens, the pathogens are Staphylococcus aureus, Haemophilus influenza, Pneumococcus, and Klebsiella, Pseudomonas, Mycobacteria and Legionella, and viruses like influenza virus, rhinovirus, coronavirus, and the fungi like Aspergillus, Mucar, Rhizopus, etc. What the indications for mechanical ventilation? The indications are to provide the respiratory support. Say the patient is comatose, he's having acute respiratory distress syndrome, cardiac arrest, he's in severe sepsis. Look at this picture of endotracheal tube. The part which is lying outside the human body, there are three openings. One is the port which is used, the middle one is the port for connecting to the ventilator. Other is a suction channel which is used to suck out the bronchial secretions which pool in above the uh, uh, within the throat. And other one is a pilot balloon which is used to inflate the balloon which is present near the ET cuff. Okay, so once you introduce the ET tube, it reaches just above the trachea, and there's a ET cuff there which can be inflated by introducing the sterile saline through the balloon port. And what happens when this endotracheal tube is inserted? Actually, it's aerating the mucosa. It is inhibiting the uh, clearance of ciliary clearance mechanism of bronchial secretions. So they try to pull up above the ET cuff. So this is a ventilator which is connected to the ET tube through. And then if you look into this mechanical ventilator, it has certain tubes known as ventilatory circuits. From one side, if you see the arrow, the air is coming out from the ventilator. It is introduced into the humidifier, and then it reaches the patient, and the expired air is also coming out and entering into the ventilator where it is filtered. So what is the role of humidifier? You're not breathing through the nose, so nose helps humidifying the air so that the respiratory epithelium is intact. So humidifier plays a role of the nose. You can also see that you put in a nasogastric tube so that you can feed the patient. What does this nasogastric tube do? It disrupts the esophageal sphincter. So there might be aspiration of GIT contents. They can enter the trachea and further enter into the lungs, causing infection. Now let us look into the sources of ventilator associated pneumonia. The main sources are the oropharyngeal pathogens or the gastrointestinal flora. Next is the aerosols which are present in the environment like Mycobacteria, Legionella, contaminated respiratory instruments. We already discussed the ventilatory circuit or the suction catheter which is attached to the suction port to remove the bronchial secretions which have pooled in above the ET cuff. Bronchoscope, all these are sources of infection, and healthcare workers as such, if they don't follow standard precautions, they can be the source of infection. Looking into the pathogenesis, first let us understand the routes of transmission. The most common route of transmission is aspiration of microbes which have colonized the oropharynx or the gastrointestinal tract. Others are the direct inoculation, that is from the hands of healthcare workers, or inhalation of aerosols containing bacteria through the humidifier or from the environment. And the rare source is hematogenous spread from IV catheters. Say you have placed an IV catheter in that patient, that is a primary source of infection which has entered the lungs to cause a secondary infection. Further looking into the pathogenesis, so if you look into the pathogenesis, whatever flora is colonized in the oropharynx enters the secretions which have pooled up above the tracheal or ET cuff, as well as this aspiration of GI flora because of the use of nasogastric tube and disruption of esophageal sphincter. And these bacteria present in the secretions, by microaspiration, they can pass through the cuff and reach the lower respiratory tract or the lungs to cause ventilator associated pneumonia. Okay, and the biofilm formation is also a factor which causes ventilator associated pneumonia. Looking into the diagnosis of ventilator-associated pneumonia, the clinical criteria like fever, leukocytosis, purulent tracheal secretions, oxygenation, impaired oxygenation, or infiltrates in the chest X-ray. And the microbiological criteria are processing the samples like endotracheal aspirate, which is removed by a suction catheter, or bronchoalveolar lavage, which is subjected to either semi-quantitative or quantitative culture. Please remember, we are not doing qualitative cultures, we are doing quantitative cultures. So the count of the bacteria is it plays an important role to know whether this infection is present or not. So the significant count for ET aspirate is more than 10 to the power of 5 colony forming units per ml of sample, and for bronchoalveolar lavage it should be more than 10 to the power of 4 colony forming units per ml of sample. So there's one score known as clinical pulmonary infection score, which includes all these 6 parameters like tracheal secretions, chest x-ray, temperature, leukocyte count, oxygenation parameters, and the culture results, which when we add up comes up to the score of 12. When the patient has score of more than 6, it is considered as ventilator associated pneumonia. Looking into the prevention, prevention can be done by routine or daily chlorhexidine mouthwashes, because there's colonization of flora in the mouth. Next, we can prevent the microaspiration of GI contents by elevating the head to up to 45 degrees. Then daily aspiration or frequent aspiration of these bronchial secretions with the help of suction catheter, and properly maintaining the ventilatory circuit. It can be in place for 7 days unless otherwise indicated to remove, and cleaning or changing the humidifier every 5 to 7 days, and using a closed suction system to avoid aerosolization of inhalation of these pathogens. So thank you, students. In the next class, we'll be discussing about catheter-associated bloodstream infections and surgical site infections. Thank you.